Good morning, everyone. Thank you very much for joining us today. As you know, October is Breast Cancer Awareness Month, and at QBRI we have annual public events and seminars in participation with other entities as well as our own events. So of course, this year it's a little different and our activities are online. So in this webinar, we've joined forces with Hamad General Hospital, and our main guest today is Dr. Salha Mujassoum Al-Badr. We thank you so much for being with us today and taking the time out from your clinics. I'm sure it's a busy time for you. So just to introduce Dr. Salha, she's a senior consultant of medical oncology at the National Center for Cancer Care and Research. She's chairperson of medical oncology and palliative care medicine, and also the CEO of Zena Sanitizer Factory. I must say it's an excellent time to be the CEO of a sanitizer factory, so best of luck with that. And in addition, Dr. Salha holds multiple positions in the cancer hospital, such as clinical lead of breast cancer program since 2005 until today, lead of the National Clinic Advisory Board of Qatar Breast Cancer, and Fellowship Program Director of Medical Oncology since 2011 till today. And also she's the Director of Cancer Hereditary Genetic Program. Dr. Salha obtained her Bachelor of Medicine and Bachelor of Surgery from King Saud University in Riyadh in Saudi Arabia in 1992, and finished postgraduate studies in Canada and received the specialty certificate in internal medicine and hematology from the Royal College of Physicians and Surgeons in Canada, Toronto, in 2000. She obtained additional certification by the American Board of Internal Medicine, Clinical Hematology and Medical Oncology from Toronto also in 2000, 2001 and 2004. She was appointed as consultant in hematology and oncology at Hamad General Hospital from February 2003 to 2005, where she was promoted to senior consultant in hematology and oncology in NCCC in 2005. She's a member of international oncology societies such as ESMO, ASCO, in addition to International Agency for Research in Qatar, the Scientific Council. She served on many HMC committees, including Hospital Research Committee, Medical Education Committee, and her research activities are focused in breast cancer, gynecological malignancies, and cancer genetics. She has multiple active grants from the QNRF, and she has been author of several publications and guidelines. She established multiple services unique to cancer program, and one of those is the ACGMEI Accredited Medical Oncology Fellowship. She's the founder of hospital-based standard risk breast cancer screening in 2008 before launching the national screening, and founder of Hereditary Cancer Genetic Program in 2013. Breast Tumor Board in 2005 before launching the cancer strategy. She's a lead of clinical advisory for Cerner Oncology Solutions implementation team in 2015, and clinical lead with UHN HMC collaboration breast cancer in 2016. In recognition of her efforts in improving patient care, she received 6 Star of Excellence Award for the last 3 consecutive years. In addition, she's the chair of organizing committee of annual breast cancer conference, which is held regularly in the month of October for the last 6 consecutive years. And last year she held joint breast cancer and gynecological malignancies conference, along with her active role in public breast cancer awareness, and most recently awarded 2 certificates for patient experience forum in 2019. So after this very impressive resume, we have a perfect person with us today to talk to us regarding this field. And I'd like to hand over to her now for her presentation on breast cancer in Qatar, achievement and future direction. And in the meantime, if anyone has any questions during the presentation, you can write them in the Q&A box, and we'll be sure to address these accordingly, or alternatively, there will be a chance to ask questions after her presentation in a Q&A session. So this session will be recorded, and Dr. Salha, if you'd like to begin, the floor is yours.
Thank you so much for nice introductions. The breast cancer month, it is a unique month, and usually we would like to participate to raise awareness for breast cancer. Unfortunately, in our populations and culture, we still see patients with advanced breast cancer. We have our breast MDT. Well, I'll talk to you about it in my presentation. So all the newcomers from breast cancer, we discuss them in MDT, and we still see a lot of patients, even in highly educated patients. Still we see patient presented with advanced stage, with big tumor and axillary metastasis, which is almost disappeared from Western country. I think we have a lot of things to do to increase the awareness among people that early diagnosis can save lives. With that, I just want to start my presentation. I have no conflict of interest. So in my presentation, I'll talk about breast cancer epidemiology in Qatar, and talk about prevention and breast cancer awareness. And then we'll talk about the personalized medicine, providing patient care, and education, and our achievement in education and research. So as I know, breast cancer is the most common cancer in Qatar and also worldwide. So incidence in 2003-2007 was 45 per 100,000, and it's raised to 56 per 100,000 in 2008-2011. Qatari patients accounted for 30% of the diagnosis of breast cancer in females. The prevalent age group was 40 to 50 years old, and in the most recent published data from Cancer Registry, the median age is 47. And it is 36% of all affected women. As you can see here, the breast cancer in Qatar, based on Cancer Registry, is remarkably increasing, significantly increased with time, especially when we introduced national breast cancer screening in 2016, and reaching up to the incidence reaching up to 300 per year. So as you can see here, the breast cancer, can minimize this. Breast cancer is number one, so the percentage up to 40.8%, followed female cancer, followed by colorectal and thyroid cancer. Still, we can see also the breast cancer in it is 1 to 2%. So how we can control cancer is by early detection and prevention. And early detection and prevention can be established by implementing breast cancer awareness for signs and symptoms of breast cancer, and also implementing a screening program. And screening, it has two elements. One, standard risk screening, which is launched by National Breast National Cancer Strategies in 2016, and also we started our hospital-based cancer standard cancer screening 2008. and also screening or surveillance for patients who have genetic susceptibility, among high-risk patient who was at high risk of developing cancer by cancer surveillance, and providing risk reduction strategies for those high-risk vulnerable people. Also establish diagnosis and early treatment. The diagnosis include imaging and pathology, and very advanced pathology, including molecular diagnosis, and also implement the state-of-art treatment, including surgical management, radiation oncology, and systemic treatment, including immune therapies and the precision medicine using the biomarkers and pathology to treat patient according to their biomarkers. And most recently, the immunotherapy introduced in the breast cancer management, especially in very aggressive treatment, a very aggressive tumor, which is a triple negative. And also we have to stress on the providing along with the treatment, improving the quality of life. The quality of life not only at the end with palliative care integration, but also for better toxicity management from our that arises from our treatment, and also utilize the personalized medicine using target treatment and less intensive therapy for people who need it. And also they have to focus on survivorship. As we know that early diagnosis can lead to increased survival, especially in early stage breast cancer. And there is a lot of growing research in this area. And we need to, since that our patient survive more, so we need to identify late drug toxicity and manage them, and also establish surveillance strategies, which is called available in Qatar. So regarding improving breast cancer survivors, Qatar was involved in global surveillance of trending cancer survivor 2000 to 2014, and it's I think it's updated in Concord 3, and showed that our breast cancer survivor in Qatar reached to 70%, almost similar to the Western countries, and this is reached up to 70 to 79%, and this is almost similar to the Western countries, and this is because we have the system in place to improve diagnosis, early diagnosis, and also early management. And all systemic treatment available for free of charge. So in terms of preventions, breast cancer awareness, the Breast Cancer Awareness Month marked in countries across the world, and we also celebrate the month of October, and your participation in this actually enhances and show that we are happy to participate and to raise awareness about breast cancer. Currently, that there is no sufficient knowledge in the cause of breast cancer, therefore early detection of the disease remains the cornerstone of breast cancer control. When breast cancer detected early, and this is our own message on all breast cancer awareness, if adequate diagnosis and treatment are available, there is good chance that the breast cancer can be cured. Part of our initiatives, as Dr. Hiba, Mrs. Hiba, she introduced me, that we established pilot hospital-based projects about hospital-based screening belong to the NCCR, and we involved a lot of patients, and there was an issues related to when to start and is this acceptable for patient to have screening for people who's asymptomatic. So it was very successful, and we publish our data. If anybody want to look at our population, you can look at in evidence-based medicine practice. And finally, it was the breast cancer screening is launched as a part of Cancer National Strategy in 2006. And all the resources was available to BHCC. And initially, we in our pilot was self referral, but now we established and launched it was by invitation and included more women. And also regarding the prevention, we established, as mentioned before, the high-risk clinics officially was launched in 2013, and to manage all affected and unaffected patients with cancer, high-risk patients and their families who are at increased risk of carrying hereditary predisposition for breast and ovarian cancer. And then in 2016, the clinic has been expanding to manage patients at high risk for gastrointestinal and other hereditary cancer syndromes, including hematology and oncology cases. And if you want to have more about our population, you can follow the, it was published in the Cancer Molecular Genomic Medicine, and the title Cancer Genetic Program Follow-up in Clinical Genetics and Genomic Medicine in Qatar. As you can see, the most common syndromes available in Qatar is BRCA, breast cancer-associated genes, and account for 40% of the cases diagnosed with hereditary breast cancer. The patient care also, since we launched the cancer strategy, dramatically improved. And there is we established cancer diagnosis and referral pathways. So any patient suspecting to have cancer, they developed clinical criteria, and any health private sectors have a patient with suspected cancer syndrome or suspected cancer with signs and symptoms, we need to refer them to the tertiary hospital within 48 hours. And also we put clinical guidelines, and those patients who's diagnosed with cancer, they have to be discussed in multidisciplinary team, where there is a specialist from different subspecialty discussing the case and reaching the diagnosis. And once they reach the diagnosis, need to be treated within 14 days. And this kind of clinical guidelines is actually monitored by Ministry of Health. So we moved off from we moved toward the patient-centric approach, where the available services available for patient care, including the allied health care, outpatient clinic service provided by hospital and disease-oriented, and also subspecialty available for patient. we treated. So initially it was just dealt by one physician. Now we are, and there was like fragmented services now. We are in one cohesive team where the patient care provided by different subspecialty, and we introduce the service of subspecialty in treating patient in addition to the clinical nurse specialist and patient pathway coordinator to follow patient and provide holistic approach to patient needs. So what is the benefit of having multidisciplinary care? The aim is to improve patient outcomes by influencing various aspects of care. For example, to develop guidelines and also monitor that the patient, that the healthcare provider adhere to guidelines, and also to make sure that there is a streamline of services that are provided to the patient, and also increase surgical volume and experience for our colleagues of surgeon, and also to improve interdisciplinary working, because different people, they have different physicians have different experience and different school of management. So the input from each different subspecialty is very it's healthy environment, so to improve patient care. So the treatment by specialist surgeon, oncologist, breast cancer offer better local, regional, and systemic treatment. And this is reflected in patient, this has effect in the patient management. So instead of having individualized approach to breast cancer management, has instead of having one person who's managing breast cancer, now we have a team of experts managing breast cancer, and this has potential to offer clear clinical benefit and also ability to bring more tailored, cost-effective medicine-based evidence strategies to the patient care. So our breast team is a well-established group of experts with specialist role in diagnosis, treatment, and management of patients with breast cancer, including a breast radiologist. So any patient with symptoms, we usually see them in the triple assessment clinic, where the breast surgeons, they can provide clinical examinations. At the same time, patient will be referred to the breast radiologist. They will do imaging, global imaging, and then they took biopsy, image-guided biopsy, and the pathologist, breast pathologist will give us the diagnosis. And then usually we discuss the case in an MDT, where the breast radiologist will explain the radiology, and breast pathologist will talk about the pathology, and breast surgeon will provide local treatment, and also the breast medical oncologist, they will provide systemic treatment, and after surgery we usually discuss it also with the breast radiation oncologist to supplement a treatment if the patient has local cancer, or give palliative radiation therapy if needed. In addition, we have clinical nurse specialists for coordinating patient care and also to provide psychological support. And a patient pathway coordinator, usually the nurse, they have to guide patient in different treatment modalities. And we have administrative support for each MDTs by breast cancer MDT coordinator. In addition, we have allied healthcare, especially physiotherapy for lymphedema management, either as a treatment or Currently, all symptomatic and circulating cases refer to our hospital, should be discussed in MDT. And also, there is single named lead clinician for breast MDT designated team members. And our multidisciplinary meeting held once weekly and discuss all. As I said, usually we do have triage for all breast cases, stratify them for urgent, non-urgent, or cancer referrals seen within 48 hours by breast surgeons. And the other achievement also establishing hospital and national breast cancer guideline with an input from multidisciplinary core members. And if anybody would like to have a look to our guidelines, the national guidelines, you can visit internet, you can Google it, and you check the guidelines, national guidelines for management of breast cancer state of federal. As I already alluded, the breast cancer triple assessment or one-stop clinic within our hospital, or also we have one for symptomatic in women hospital. So we are using high standard state-of-art surgical technique to provide better cosmosis in breast complications. And also we provide the breast reconstructions for women who require mastectomy. And we have the established lymphedema working group and physiotherapy guidelines. Now we are moved from using hard copies or written prescriptions. Now all our medical records is electronic, and we develop also chemotherapy electronic prescriptions. And establish an NCR, interval professional site models of care with weekly breast meeting. And we redesign our medical oncology breast cancer team in clinic. And we have some expert monthly video conference, either with North America or with Heidelberg, or different international institutes. We have also quality projects, and one of the great quality projects that we provided is using subcutaneous formulation of target treatment, one of them is trastuzumab, and also we involve in clinical using, because initially when trastuzumab and bortezomib, which is anti-HER2 agents, available as IV only. Now, when we adapted the international guidelines using trastuzumab as subcutaneous formulation, we saved a lot of times and cost. So now we trained all the patients who require IV, who require trastuzumab, we give it as subcutaneous formulation, and we save a lot of time and effort. We already also established breast cancer survivorship, the disease treatment specific site survivor clinic for breast cancer. And also most recently, we started also establish cardio-oncology breast cancer model. As mentioned in the my section, that we have a lot of educations programs. One of them, the yearly breast cancer conference. Unfortunately, for this year, because of COVID-19, we're not able to conduct the breast cancer conference, but we have this breast cancer awareness. We've done a lot of videos related to survivorship, and also we sent a lot of messages through the Hamad media. So we already have also in our conferences, in our educational activities, bi-weekly breast cancer journal club. We have chemo class education for patient and family, and as I said, the public breast cancer awareness activities. Our team also participate in terms of research in different modalities of research. The most prestigious research was QNRF, mainly with international figures and also from different institutes. Here you can see some of those examples. And also there is HMC sponsor. We have a lot of research, which is, I give some of the example. Development of breast cancer survivorship program, benefit and outcomes, and role in small cell tumors. And we are doing some research related to COVID also. And we involve in different pharma sponsor, one of them registry with Middle East. And most recently, we are proud of it that we developed first clinical trials in using subcutaneous formulation of trastuzumab. So what is the future direction? I will continue using highest standard diagnosis and treatment of our patient. And now we are using systemic immunotherapy for triple negative. Also, we involve more in transition research clinical trial, and are hoping that with the biobank we can establish disease-specific biobank, and already established somehow breast oncology fellowship, but it is from surgical part, but I hope that we can do something for medical oncology. And we already started this year breast cancer survivorship, and we have allocated the clinics in ambulatory outside our cancer hospital. We have the breast cancer survivorship clinics along with other survivorship clinics. Thank you, and I hope you enjoyed my presentation.
Dr. Salha, thank you so much for this very insightful presentation about Qatar's advances and achievements. And it's very clear that you're doing a lot of work in the field, so thank you for that. And I'd like to open the floor for questions. We've had a few questions so far, if you'd be so kind to answer them. So Dr. Adviti is asking about your pilot study. So your pilot screening study included 75% of non-Qataris and 25% Qataris. Does this show the general population epidemiologically, or social stigmas playing a role in these percentages?
Yeah, this is very great questions. Our pilots actually want to show if there is acceptance from our population involvement of breast cancer screening. So as you can see, like in breast cancer epidemiology, so because we are a small population, the national is almost like 30% of patients from Qataris is diagnosed with the breast cancer. The majority is non-Qataris, and I think it is also reflected in our pilot study for screening. And of course, there is, if you can go to also we did one studies by, I think it was QNRF supported, and it was, I forget the name, but it is attitude of women toward the breast cancer screening. And the study actually showed that majority of women involved in screening or interviewed, even if they are not involved in screening, majority of them, they knows about breast cancer screening methods and self-assessment, but they are not engaged to breast cancer screening practices for the reason that you mentioned. Stigma, fear, and this is also explain why our patient presented with locally advanced or stage 2 breast cancer, and they don't go for screening. Usually, when they become symptomatic and it becomes big or have the symptoms, then they comes to medical attention.
I mean, yeah, that's very unfortunate. And this is the whole reason why we try to do these campaigns every year. And as you said, it remains a taboo in various cultures, including our own Arab culture. So, you know, everyone's playing their role in trying to increase awareness. Do you think the family GP could play a role? And how could this be implemented in Qatar? And in conjunction, I've personally thought about, through these challenging times with the recent pandemic, I've thought a lot about how these women mainly who are already going through a very difficult time physically, mentally, socially, how the response has been during the pandemic. Are ladies still keen to come to their chemotherapy sessions? Are they still keen to get their regular screening, or has this added to the struggle that we're already facing?
The thing is, this is like the screening as a national screening was actually put in hold because this is, you know, we especially with this crisis with the healthcare. I think all screening was stopped during this period, and majority of the patient they comes during if they have symptoms, and as I said, probably this is affect negatively in women because there is a lot of services kept on hold, and there was a little bit difficulty in access or some issues related to the patient themselves. They don't want to go and come to hospital. Some of the you know, although like you know the all services for cancer for patients who symptomatic was fully operated. Like our hospital, we continue to provide breast or cancer services, including like you know chemotherapy, radiotherapy, surgeon. Usually, just because the cancer we cannot stop a patient from coming or delay their treatment. I think it's more it comes from the patient themselves. They are so worried to come to hospital.
Yeah. So we've had another question regarding the chemo classes. You said it's one of your educational activities. Could you please elaborate on this? Do you have programs for like psychological support and other activities such as wellness programs to help cancer patients feel more like themselves again after remission or during?
Yeah, this is one of our biggest achievements because we have collaboration with the UHN, University Health Network, and one of the classes is chemo classes because patients they need to be aware of you know toxicity, how to get help. So the chemo class we have actually awarded two hours for establishing this program because it's beneficial for the patient, and we have very positive feedbacks from the patient who attended the class. It is actually multidisciplinary educational sessions. So they deal with the like you know the orientation about the chemotherapy toxicity, and also the education about the diet and physical activities and everything related to sexuality with the partner and these things. Sometimes sensitive question they cannot talk with the doctor themselves, but it is run by clinical nurses, specialist, dietitian, pharmacist, physiotherapist. So and we did also videos, a video about patient journey. From time of diagnosis till involved in the chemotherapy, we talk to them about the infusion of chemotherapy with the expected side effects. And it is community actually community activities, because you know the Rayan channel supported us and they did the videos for these sessions. And I think if anybody wanted, it was I think it is available in our website for patient who's going through the chemotherapy.
Oh, that sounds very interesting and very insightful. So I encourage everyone to go check that out. And we've had another question from
Yeah, the
Shireen.
other related to cytology, we have psycho-oncology department. It was started since we have our hospital, but now we are hired more psychologists and 2 psychiatrists, and we have a lot of ambition to involve them in group sessions and also involve them in the survivorship. As I told you, like the beginning, we have research already approved by ABHAP to assess the quality of life. And also we're trying to implement for all patients a distress thermometer. So all comers for newly patient diagnosed with cancer, we assess their stress by scoring system. And any patient who has a high score of distress, we refer them to psycho-oncology.
Okay, thank you. We've had another question from Sireen. Thank you for your question. She's saying, can you please elaborate on the immunotherapy you use for triple negative breast cancer and the survival and response?
Yes, recently, and it is recently also published, Ambition 31, using atezolizumab, and it is FDA approved medication, using atezolizumab with protein-bound Taxol, which is the Abraxane, in combinations with immune therapy, PD-L1 inhibitor, for metastatic breast cancer triple negative as a first line, and showed good benefit of overall survival of 10 months compared to a few months. So it is the people who received immune therapy survived 10 months more than the people who didn't receive immune therapy during the chemotherapy. So it is now one of our standards for patient who has a triple negative metastatic at the beginning. As a first line, we utilize this immune therapy with chemotherapy.
Thank you. That's good to hear. So, finally, where should I go if I'm worried about developing breast cancer or someone in my family has been diagnosed? What are the steps to go through to have a consultation and to receive advice?
Yeah, we usually don't accept self-referral. So if you have any doubt, you have to go to your primary center. They have to check it out. We have very clear referral criteria, because there is very specific. If there is family history of young onset breast cancer, like below age of 50, or like or family history of early age ovarian cancer, or male breast cancer, or personal history of a breast cancer at young age, less than 40, and also presence of triple negative breast cancer. So we usually accept those patients. As majority of referral comes to us, because they are worried, but there is no specific family history, or maybe they have, not first degree relatives, like maybe second or third degree relatives, and they develop cancer at older age. So we usually don't accept those. So the hereditary cancer, usually they have very specific criteria.
Okay, Dr. Talha, so thank you so much for answering our questions and for your participation. I mean, it's clear that you are a well of knowledge on the subject, being out in the field and in the clinics clinics. So thank you so much for that. And if no one else has any more questions, I'd like to move on to our next speaker, and that's our very own Dr. Julie. So I'd like to introduce Dr. Julie. Dr. Julie de Kock is a scientist at the Qatar Biomedical Research Institute, QBRI, and holds a joint assistant professorship at the College of Health and Life Sciences, HBKU. Dr. de Kock was awarded a master's degree in biomedical sciences in 2002 from the Free University of Brussels and a PhD in cancer biology in 2008 from the Catholic University of Leuven. Prior to joining QBRI in 2013, she was a postdoctoral fellow in the cancer biology group at the University of East Anglia in the UK, where she investigated the role of proteases in modulating the tumor microenvironment. In 2016, Dr. de Kock established her independent research group at QBRI, and her current research focuses on tumor antigen discovery and the tumor immune ecosystem in breast cancer, with the ultimate goal of identifying targets that can help advance the development of new treatments and improve clinical outcomes of breast cancer. Furthermore, Dr. de Kock is currently investigating the dynamics changes that occur in the host's immune response upon SARS-CoV-2 infection. Her track record includes more than 30 peer-reviewed publications and more than 1,260 citations and an H-index of 19. She sits on the editorial board of Frontiers in Oncology and the Journal of Translational Medicine, and is an ad hoc reviewer for several international peer-reviewed journals. She also serves as an internal grant reviewer for several national and international funding agencies. Dr. Julie has always been active with us annually at this time and gives awareness seminars continuously and at universities. And just last week, Qatar National Library selected Dr. Julie as an award winner for the Individual Open Initiative Award, which was launched this year, and it's given to the best applicant for their contribution to the advancement of open scholarship in Qatar. So congratulations. And again, if anyone has any questions during or after the session, we'll follow the same system. And thank you, Dr. Julie, for being with us today, and the floor is yours.
Thank you so much, Heather. Let me share my slides. All right. First of all, thank you for the really kind introduction and the congratulations. It's really kind of you to acknowledge this. So yes, as Heba was mentioning, I'm quite a strong supporter of the breast cancer awareness campaigns every year, because I think, as my slide is saying, awareness is actually leads to power. So if you have knowledge, it empowers women, and specific in this case. So today, let me see if my slides, are my slides changing? No. Yes, now it's working. Okay. So what I'm going to talk to you today is briefly about breast cancer risk, because Dr. Salha already touched upon some of those aspects. I'm going to discuss a few of the symptoms of breast cancer, which I think is really important in the context of awareness. And then, of course, what can you do yourself to reduce your risk and to take the first steps towards prevention and early detection. And then finally, in my second part, I will talk about some of the recent research trends that are emerging in breast cancer research specifically, and what we at QBRI are doing to help in the fight against breast cancer. So first of all, okay. So as Dr. Salha already pointed out, approximately 1 in 8 women around the globe will be diagnosed with breast cancer during their life. If you compare this to men, because it's important to mention men do get breast cancer as well, but the risk is much lower. So in men, it's about 1 in 1,000 men which during their lifetime will be diagnosed with breast cancer. Now, if you think about breast cancer, I think it's also very important to highlight that only 10% of all breast cancer cases or linked to a hereditary risk or a familial risk. So, because often people think that, you know, I might have one cousin or one aunt or somebody in my family who has breast cancer, so I will get it as well. No, it's actually only 10% of all breast cancer cases that are familial. As Dr. Salha mentioned, there are really strict criteria as to when you would be considered at a high risk due to familial history. And I put here the example of Angelina Jolie. So up to today, we know that the breast cancer susceptibility gene 1 and 2 are the major drivers of hereditary breast cancer. So if there is any genetic alteration or in those genes, the risk of developing breast cancer actually increases to 55 to 80%. And this is why women that have been diagnosed with genetic alterations in those two specific genes, they often opt to have a preventative mastectomy, such as Angelina Jolie did. So I do think that from her story, actually, a lot of people have learned something about breast cancer risk and hereditary breast cancer. So it's important that people with such a high profile actually come forward as well. Now, if we look at the numbers, so at the left-hand side, you can see the numbers globally, and on the right-hand side, I put some numbers from Qatar. So these are numbers that were published in GloboCan 2012, which is an online platform that is accessible to all, and that has the numbers for all the different countries and regions that are participating in this international effort. So as you can see, this is the numbers for the 5-year prevalence, which basically means the number of patients. And as you can see, I highlighted breast cancer in both panels, where you can see that if you look at women specifically, breast cancer is the top #1 most common cancer, globally as well as in Qatar. And you can see that in Qatar, the number is slightly higher compared to what we see globally. So in general, what we say is that every 2 to 3 minutes, a woman is being diagnosed with breast cancer. Now, if we look at the death rate of breast cancer, again, left panel for global numbers, right panel for Qatar, we can again see, if we look at women, breast cancer is the top #1 deadly cancer type in both globally as well as in Qatar. However, if you look at the numbers of the cases compared to the number of deaths due to breast cancer, it's actually lower. So although breast cancer, yes, it's the most common, it's the most deadly one, it does not mean that all women that have breast cancer actually die from breast cancer. And this is where breast cancer awareness plays a huge critical role. So 90% of people that have been diagnosed at an early stage with breast cancer will survive at least 5 years after their diagnosis. So this is a very important message that we need to send out to everyone. Now, what are the risk factors of developing breast cancer? Well, it's important to know that there are some things you can control and some things that you cannot control. So if we go through those. So things you can control are, for example, weight, diet, excessive alcohol use, smoking, and exercise. Things you cannot control, obviously, are your gender, so the fact that you're a woman, your age, family history, and the time where you went into menopause or the time where you got your first periods. These are things we cannot control. However, as you can see, there are quite a number of things we can control. So again, weight, diet, this all goes back to obesity, excessive alcohol use, smoking, exercise, so basically trying to stay healthy. Some of the things I put between both of those categories, for example, exposure to hormones, because we cannot always control this, right? So we can control to some extent our exposure to hormones, but it's not all in our hands. So that's why I put it as a category in the middle, basically. Now, if we think, so these are risk factors that we know are important for women. However, we have to keep in mind that also men can have breast cancer. So what are the risk factors for male breast cancer? Well, basically, they're very similar. So as you can see, again, we have those BRCA mutations, more specifically the breast cancer susceptibility gene number 2. We have aging, we have hereditary factors, we have excess body weight, alcohol use, and more specifically in male, we also have like chronic liver disorder. So how do alcohol use, chronic liver disorder, and excess body weight increase the risk of breast cancer in male? That is because of the hormonal dysregulation. So all of these 3 factors actually kind of dysregulate the levels of the male hormone testosterone compared to the estrogen level, because men also have estrogen hormones, but at the different levels. But those factors actually make a disbalance in the level of testosterone compared to estrogen. So there is more estrogen. And as you might know, estrogen is one of the female hormones that is also driving breast cancer growth. So if you have a tumor, this hormone will actually fuel the tumor to grow. So I think this is a very, very important question, and it is something that I have asked myself as well, and I think everybody should ask, male or female or male even. Should I worry about a lump in my breast? Well, the good news is not immediately. 80% of breast lumps are non-cancerous. This doesn't mean, of course, that you don't should go and have it checked out, but you don't have to go immediately in a panic mode and you know, have those doom scenarios in your head, because 80% is non-cancerous. And how is this possible? What are those lumps? Well, it could just be, you know, like a bruise from a trauma. It could be infection. It could be cyst, which is very common, especially in older women. Could be calcifications. And then we have some specific diseases or syndromes, which are fibroadenomas, which are more common than in young women compared to cysts, for example, and a fibrocyst, which can basically be more apparent during certain times of your monthly cycle and then disappear later on. So again, you should not go into the doom scenarios. You should not immediately panic if you feel something. But of course, please go and have it checked out. Now, I really, really like this visual because it's something that, you know, something visual you will remember. And it shows you the different symptoms that can occur when you have breast cancer. So first of all, it doesn't mean you need to have all of those to have a breast tumor. And it also doesn't mean that if you have one of those, you have breast cancer, okay? But if you have multiple ones of those together, then it could be an indication that, yes, you might have to go have yourself checked out. So the first one is, of course, to have a mass, a lump. Second one is when you have an indentation in the skin or your skin shows some signs of erosion or redness, heat. You have some fluids from the breast, which is often like more dark blood colored. You have some dimpling, so it looks like an orange skin. You have your breast suddenly changes shape, or your nipple is retracted. You have more apparent veins. You have very clear bump, and so on. So those are symptoms that might trigger you to say, hey, something has changed. I need to go and have it checked out. So saying this, what can you do? Obviously, you can have your monthly breast self-examination. The reason why we say monthly is because during the monthly cycle, the breast structure does change. So it is important to familiarize yourself with how your breast looks like and feels like, so that if there is any really obvious change, you can detect it. And there are stories that, I mean, from women that have actually detected early stage breast cancer themselves. The second step is to have your yearly clinical exam by a physician, where they just examine the breast themselves, or you can go for a mammography. As far as I know, the guidelines in Qatar say that you should go for a mammography when you're 45 years or older. And as I mentioned, there are, as far as I know, again, there are 3 centers within Qatar that offer the mammography as part of the primary healthcare center. Why is mammography so important? Because it can help to reduce the breast cancer death by 15 to 25%. Because again, we have an earlier detection. So you can have 3 layers, let's say, of early detection, which is 1, yourself, 2, your physician by a clinical exam, and then 3, the mammogram. And I put this visual because, again, I believe visuals are say much more than just words. So as you can see, this is just a representation with pearls of the size of a tumor that you yourself can detect. So the monthly self-exam at the bottom. And then if you compare it to regular mammograms, for example, which is the top left, you can see that having a mammogram can detect tumors or lumps when they are much, much smaller than when you can do it, or even when your physician can detect it by physical exam. So in my second part, I want to talk to you a little bit about the current research trends, and then about what we do at QBRI in the fight against breast cancer. So these are the 5 pillars of breast cancer care, or even general cancer care as we know nowadays. As you can see, surgery has existed since the ancient times and is still routine care in the clinic now. Then we have radiotherapy, which was implemented in the end of the 1800s and is still used nowadays. We have chemotherapy, which was started to be used in the clinics in the 1940s. And then now we have more of a targeted therapy where we actually look specifically at certain characteristics of your tumor. And then based on this, we give you a specific treatment, such as, for example, hormonal treatment. And then the new kid on the block is immunotherapy, which Dr. Salha briefly touched upon already. So basically, we are going from a one-size-fits-all, like surgery, radiotherapy, chemotherapy, which used to be given to all patients, to a more precision medicine approach, where we actually precisely look at the tumor, molecular patterns, and then basically adjust the treatment specifically for the tumor and the patient. So again, the traditional cancer care is guided by the disease stage and the hormone receptors. And I will explain in this graph what that means. So first of all, in the left figure, you can see, and I mentioned that the tumor can be from a ductal or a lobular anatomical position. So the tumor can actually origin from the milk duct, or it can origin from the lobes within the breast. So this is already one kind of classification system that is used in the clinic. The other classification system, which is really driving, as I mentioned, the treatment choice, is staging. So as you can see in the graph on the right, we go from stage 0 up to stage 4. So stage 0 is those lumps that are actually not a tumor, they are anything like benign. Then we go from stage 1 to stage 4. These are the tumor stages. And how are those stages defined? They are defined by 3 different parameters, which are defined at the bottom. You have the size of the tumor. You have the fact that the lymph nodes in your armpit, for example, already contain tumor cells, yes or no? Because the primary tumor from the breast will eventually, when it becomes bigger and it becomes to spread out, it will first kind of spread or move towards the lymph nodes in the armpit. And then if the stages advances, it will spread out throughout the rest of the body, which is basically the third parameter, metastasis. So metastasis means that the tumor has spread outside of the breast, outside of your lymph nodes, and is actually now already in different end organs in your body. And what is important about this picture is, again, that you can see that if you're early in detection, if you're at stage 1, where there is only a tumor, but it hasn't spread at all, it's really local in your breast, you have a really, really good survival rate. You have 98% survival rate. And even if it's already within the lymph nodes, within the armpit, so it has spread out of the breast itself, still your survival is really high. You have a 93% survival rate. It's only when it's starting to become really big and it has already started spreading, or if it is spreading throughout the whole of your body, that your survival rates are really going down. So emphasizing again that early detection is really the key for not only breast cancer care, but also survival. So saying this, of course, we are trying to find different ways to detect tumors earlier. So one of them is obviously the self-examination, clinical examination, and mammography. But we also have new prognostic molecular tests in the clinic. And we are trying to find also new markers or new tests that can be done on the blood to detect tumors earlier. So the tests we have now in the clinic are really to look at if you have a tumor, what different expression patterns of genes. So how does your tumor look different from a tumor in another patient? And how can this information help us to predict your survival chances, or even the fact whether you need to have additional hormonal therapy or chemotherapy? And I've mentioned 3 tests here that are already used in the clinic. So one of them being Oncotype, which was FDA approved in 2004. We have MammaPrint, which was approved in 2007. And then we have the more recent test, Prosigna, from 2013. So all of those tests use different molecular patterns of tumors to look at or to assess the risk of your of distant disease recurrence. So how much is your risk to actually have metastasis or spread of the tumor in your body, which, as you know now, significantly reduces the survival rate. So it's good to know this from the beginning so that we can adjust the treatment needed. And then the second, as I mentioned, to check if the patient would actually benefit from having additional hormonal or chemotherapy. Because if there is no real benefit for the patient, then why would you give them, for example, chemotherapy? Because it has a lot of side effects and really considerably affects the quality of life of the patient as well. So as I mentioned, this is all done on tumor tissues, so you already have a tumor. Now we are moving towards kind of diagnostic tests. So we call them liquid biopsies. So they are blood-based tests where we try to find the tumors earlier by looking at blood samples. So this is a study the test is called CancerSeek. So it is still research-based. It's not used in the clinic, but it's a new test where they found that they can detect cancers early. And it's actually looking at 8 different cancers. As you can see, it's esophageal cancer, lung, breast, liver, stomach, pancreas, ovarian, and colorectal cancer. And what they do is they just take one blood sample and they look at both the DNA in the blood as well as proteins. The reason why is because when cancer cells, for example, die, they will shed the DNA in the blood as well, so we can detect this. And what they found is that if you look at the 8 cancers together, we have about 70% chance to detect the cancer. Some cancers we can detect more easily than others. For example, ovarian cancer has a 98% detection rate. Unfortunately, breast cancer was the less sensitive test. Only 33% of breast cancers could be detected using this blood-based assay. So there's still a lot of research to be done to optimize this, for example, for breast cancer. So saying this, I just want to share a couple of slides about how QBRI is helping in the fight against breast cancer. So we have this interdisciplinary research program which focuses on breast cancer. So this is an institute-driven program. Although it is focused on breast cancer, it uses expertise from within the whole of the institute. So it's a multidisciplinary approach. And the program is focused on identifying diagnostic, prognostic, and predictive biomarkers in breast cancer. And as you can see in this figure, I'm not going to go through all of this, but I just wanted to again highlight that We do have heterogeneous patient population, so one size fits all kind of treatment approach does not work. We need to go again towards the precision medicine. And what this program is about is that actually we will look at tumor tissue as well as blood and perform different types of assays, which we call multi-omics, to look at different aspects of a tumor cell. Could be looking at the genetic information, the DNA, could be looking at the molecular patterns that are expressed within the tumor or in the blood, could be looking at proteins, it could be looking at metabolism, and so on and so on. So it's a multi-omics approach, looking at both tumor and looking at blood tissue, with the aim to identify certain molecules that can help us towards precision medicine. And as I mentioned here, there are two major aspects within the program. One is to look at genetic susceptibility to hereditary breast cancer. And the second one is to look at both tumor tissue and blood markers that could be used to distinguish breast cancer patients from just normal healthy subjects, as well as to distinguish patients that respond to, for example, hormone therapy, chemotherapy, versus those patients that do not respond. So again, similar to what I described to you about a molecular test, trying to find some kind of assay that can predict whether this patient would benefit from a certain type of treatment, yes or no. But here, again, we would look at both tumor tissue and blood, because if we have a blood assay, that will make it much easier and much more comfortable for the patient as well. So if I can go back to this slide, basically what we are trying to do with this program is going again from the one size fits all towards the precision medicine, incorporating all those different aspects of a tumor itself and then its signature that is reflected in the blood. The last pillar, the new, most, like as I mentioned, the new kid on the block, immunotherapy, is also something that QBRI has been looking into. And just briefly, what is immunotherapy? So immunotherapy is basically a new kind of treatment approach where we use our natural defense system, our immune response, to fight cancer. Because how the immune system works is that it doesn't recognize our own normal cells, correct? But it can recognize something that is abnormal, whether it's a virus, a bacteria, or an abnormal cell, such as a cancer cell. So to make sure that our immune system does not recognize our own cells all the time and basically attacks and destructs our own cells, which is also known, for example, as autoimmunity, there are different mechanisms built into our own body that to make sure that the immune system is active, but it's not reacting towards our own self-antigens or to our own cells. And on the right, I just show you a picture because I really like this kind of visualization again, where you can see how an immune cell, which is smaller than a cancer cell, but it can completely destroy a tumor cell. So as I mentioned, within immunotherapy, we have different approaches we can use. First of all, we can kind of boost the immune system. We can give the patient certain cocktails of molecules that will make the immune system more active, more stronger to fight the cancer cells. On the other hand, we also have approaches where we try to awaken the immune system, because often tumor cells are very smart and they are able to kind of put our immune system into a sleep mode. So we also have now approaches where we can awaken the immune system. And the third one is the immunotherapy approach where we re-educate or teach immune cells to specifically recognize cancer cells. And this is really where precision medicine plays a role, because every patient, every tumor will be different. It will have different molecular patterns, which you can see as, you know, the red flag, the signals on the tumor cell that will signal it is not a normal cell, it's a tumor cell. So again, here, we need to see for each patient, each tumor, what are those signals, and then take the immune cells from that patient and teach them how to recognize those signals, and then basically give them back to the patient so they can go and do the job to find the tumor cells that they were taught to recognize and to kill them. So this is just a summary picture of what we are trying to do within QBRI in the context of breast cancer. So first of all, we are tackling breast cancer from different aspects. We are looking at trying to find new markers, for example, the blood-based assays or new genetic markers that can help us predict the risk for familial breast cancer within the aspect of earlier detection. And as I mentioned, we are looking to find tumor and blood markers that can help us to predict the clinical outcome of the patient and whether the patient should receive a certain treatment or not. And then finally, for example, as I just mentioned about immunotherapy, we're also looking at new targets that we can use for treatment, whether it is as a direct targeting or whether we go through immunotherapy. And with this, I want to end my presentation. I just put this two quotes here, which I think are really inspiring. They're actually coming from breast cancer survivors. So this one lady said that once I overcame breast cancer, I wasn't afraid of anything anymore. So I think this is a really powerful message. And then in the other message, basically, it says, you're strong, you are awesome, you are loved, you are not alone. You are tough, you're courageous, you are brave, and you are a fighter. And I think the sentence which is highlighted in black, you are not alone, is crucial here. And again, this goes back to the breast cancer awareness. Women that are going through this or that might be at the start of this journey have to know they are not alone. Thank you. I will take any questions if there is any.
Thank you so much, Dr. Julie. I really enjoyed your presentation, and it's really nice to see the numbers and the statistics and the visuals. It provides a much needed both shock and inspiration to the system and emphasizes the need for early detection and really gives you a push to pay attention to changes and the signs in your body. So thank you so much to that, and our hearts go out to everyone who's going through this. You're right, definitely not alone. And do you know of any platforms that people can connect with other people that are going through the same thing? Because as you mentioned at the end, it's really important to feel like you're not alone.
Yes, well, I'm not aware of anything myself, but as we just heard from Dr. Salga, I think the psychological support groups are really important. I can only speak from my experience from in the UK, where they are really, they invest a lot in those breast cancer awareness campaigns and charity groups and so on. And from my experience there, I know that, for example, they have this kind of walk-in support groups where people can go, whether it's the breast cancer patient themselves or the family members, because often family members are forgotten as well. And the effect on the family members might be, tremendous, and you don't really realize. So I know that there are support groups like this existing, for example, in the UK. However, I don't know how it is happening here. But again, I'm happy to hear from Dr. Salga that she mentioned that, yes, there are at least support groups for mental health and within, the NCCCR environment. Because I think it back to the breast cancer awareness. If we can make people more open and more aware of this, people will come together automatically.
Yeah. The good thing about social media now is, I think there are a lot of online platforms if anyone was searching to reach out to other people. And we have another question from Geeta. Thank you for your question. She said, what is the test for finding if you have the gene for getting breast cancer? So I think you mentioned the hereditary ones.
Exactly. So I'm assuming, thank you, Geeta. I'm assuming you're referring to the breast cancer susceptibility genes, BRCA1 and BRCA2. So again, this goes back to the work that Dr. Salga is doing. So she is running the high-risk breast cancer clinic in Qatar. And as she mentioned, you cannot self-refer directly towards this clinic, but if you go to your primary healthcare center and you're I don't want to say eligible because this sounds wrong, but if your profile fits the criteria that would indicate that, yes, you have a high risk of probably having familial breast cancer, your primary healthcare center will refer you to this clinic. And then within this clinic, there are genetic counselors, and they will do they will look at specific alterations in those two genes, and also at some other genes that we know are often altered in breast cancer. So they will do those genetic tests, and if then it comes up that, yes, you have an alteration in those genes, which might explain your that you have a higher risk of having familial breast cancer, and again, that will be reflected then in having family members with breast cancer as well, then they will take care of your cancer care. You're muted, Hiba.
Thank you. We have another question from Serene. Can you please? Oh, I think we've had this one. Yeah. So I was just wondering, do you see the potential now? There are new therapies coming into light, such as non-coding elements in our genetic makeup. Do you see a promising future for these types of therapies from your research and experience?
Well, it depends what you're looking at. I mean, there's two major aspects of breast cancer research. And as I mentioned, one is to find new targets for treatment. The other one is to find biomarkers that can indicate that you might have cancer, or that might indicate your survival rates, treatment response, and so on. So it depends what you're looking at. If you're thinking about treatments, then I still think that, I mean, you need to have a protein. I think it would be very hard to really develop treatments that will impact on, for example, non-coding RNAs or microRNAs. If you're thinking about biomarkers, then for sure. For example, if you think about prostate cancer, there are some urine-based biomarkers that are actually microRNA-based. So for this purpose, yes, I do think that those new upcoming types of molecules or RNAs could be useful.
Okay, thank you very much. Does anyone else have any questions? Would anyone like to jump on and ask Dr. Julie anything? Please feel free. Show yourselves. Okay, so if no one else has any more questions, I'd like to close the session by thanking our speakers, Dr. Salha and Dr. Julie. Thank you so much for your services, both in the clinic and in the research fields, and I'm sure your efforts are much appreciated and valued, especially in such challenging times. And if anyone has any questions they want to ask them privately, their contact details will be displayed, so feel free to contact them for any specific questions. And as I mentioned, this session will be recorded, so you can refer back to it at any time. And also, thank you to everyone for your participation and your attention, and I wish you all a great day ahead, and please stay safe. Thank you.